bone growth. And we're building on from where we just came from. So where we just came from was, after we're born, we have these long bones that have these epiphyseal lines. And we have cartilage that's organized. It's not just simple enough to say there's cartilage there and then it ossifies and you grow. I want to explain more of the physiology. But the structure of the long bone now sets up the stage where we can actually start elongating the bone, and that's where you grow from where you were height-wise at 5-year-old to a 10-year-old, to a 15-year-old, to an 18-year-old, to a 20-year-old, and then by then, many of us are done growing. Okay, we'll talk about some of those details and those differences in men versus women. But for right now, let's just stay true on this topic so I don't get ahead of myself. The epiphyseal side is where new cartilage is added. And on the diaphysis side, this is where osteoblasts come in and start producing bone. So depending upon where we're set up, you're going to have more cartilage being added to that plate, that growth plate, or you're going to have osteoblasts coming in and starting laying down bone. This would be called interstitial growth when we see post-development. So in utero, we have intramembranous and endochondral. Once we're born, that's all done. Now we have interstitial growth, or we have appositional growth. Appositional growth is the growth in diameter of the bone. Interstitial growth is lengthening of the bone post-in utero development. So we kind of have 4 different terms that we need to know. The last lecture talked about what happened when you're in the womb. Intermembranous and endochondral. Now that we're born, as a child, we still have the ability to lengthen the bones, but we call it something different. Now we call it interstitial growth. If we want to increase the diameter, or the size, or the girth of the bone, we'll call that appositional growth. So if we zoom in on this region, let's take a look at this. This is histology. This is a hematoxylin eosin stain of this epiphyseal plate. This process, endochondral ossification, this is described on this slide as what happens in utero. That's why it's called endochondral ossification. However, you could substitute here with a line. This is also the same mechanism by which interstitial growth happens post-birth. Make sense? So we have 5 zones of cartilaginous cells. We have the zones listed here. Here is a box right here showing zone 5 on the diaphysis side and zone 1 on the epiphyseal side. If I zoom into that rectangle, you can see zone 1, zone 2, zone 3, zone 4, zone 5. So zone 1 is called the zone of reserve cartilage. This is resting hyaline cartilage. It's pseudo-colored on this little far right tab. These are fake colors that correspond to the color of the label so that you can see exactly what we're talking about. In the body, it's not really yellow right here. Okay? It's actually not even purple. We stained it purple, but this would be more representative of the type of stain you would see. And the other thing you have to appreciate, it's more obvious in zone 3. Zone 3 doesn't go straight across. Do you see how zone 3 kind of takes this arc? Because think about the top of a long bone. Is it actually perfectly flat? No, it kind of has a curve to it. So these zones are kind of in these rainbow-like bands. It's not as obvious up here. This looks a little bit more like it's all the way straight across. But you can kind of see where zone 1 and 2 delineate right here. You see that little turn? Can you appreciate that? Some of you are like, I have no idea what your laser is pointing to. You just have like tremors. Okay? No, I'm actually really trying to show you right here where that curves down. Zone 2 to 3, right here. Zone 3 to 4, right here. But actually, zone 3 to 4 kind of does this little turn. I was tracing it. Right? And then zone 4 to zone 5 is like here. See that? So, zone of resting cartilage up top. Zone of cell proliferation is this layer right here. This is where the chondrocytes line up and they start to multiply. They're gearing up to create additional bone. Remember, endochondral in utero and interstitial post-birth all utilize cartilage to begin with. So you first multiply the cartilage. Chondrocytes, that's cartilage cell. That's what that word means. Cyte, remember cyte is a cell. Chondro is referring to a cell that makes cartilage. Then, this one's really easy to see in my opinion. This is zone of cell hypertrophy. Do you see how these guys are swollen? Like little Arnold Schwarzeneggers? You see the little dot right here? And then look at the size of the cytoplasm compared to these guys up here. These guys are like all bulked up. These are enlarged cells. Can you see that? How they're kind of like poofed out? That's the zone of cell hypertrophy. They're resting, then they multiply, then they enlarge, okay? Then you have them starting to calcify. You see, this is calcified bone right here. And you can also see labeled in this region where you're depositing bone down here, you got osteoblasts starting to show up. These osteoblasts are here. Why do you have osteocytes? Some students are like, I thought we were making bone. What are the osteocytes doing there? Why are the osteocytes there?
Release calcium.
What's that?
Release calcium.
They release calcium. But if you're forming this bone down here, structurally instead of physiologically, why? My question is more structural. Why would you need osteoclasts? Osteocytes, excuse me. Osteocytes residing here. So the osteocytes are just the final mature bone that's going to stick around. Right? Now, the label doesn't have it, but you will see osteoclasts as well. Why would you have, a tougher question, why would you have osteoblasts turn into osteocytes? Remember that from the, like 2 lectures ago? Now, I haven't labeled it, but you can put in here, you also see osteoclasts. Why would you have osteoclasts there? What's that? Maintenance? Yeah. What does this word say? Trabeculae. What does that mean? Or spongy. What does that tell you if there's... Is it a solid sheet of bone that you're making? No, you hollow it out, remember? So you have these osteoclasts carving out your trabeculated formation. Okay? So that's the whole picture I just described. These, on this side, explain what we just talked about. You've got your zone 1, reserved cartilage. Zone 2 is our proliferation zone, right? And where the chondrocytes multiply. Same picture, just different language on the next slide. Zone 3 is our hypertrophy Schwarzenegger zone, okay? Zone 4 is our calcification zone. That's where you start bringing in osteoblasts initially. Zone 5 is where they really show up because they invade and they really lay down bone matrix. And then when they're done doing that, they differentiate into osteocytes and they stick around because those are the mature bone cells. And you will see osteoclasts during the development phase, but then they go away because you need to carve out the trabeculae and have some resident for maintenance, but you don't need them forever. So what this looks like, can we dim the lights just a tad here? I don't know if you can hear me. The music must be way too good. So this is the epiphyseal plate. Here's the femur of this patient. This is the right leg, correct? Because the fibula is on the, what? Medial or lateral aspect? Lateral aspect. So this is the patient's right leg. And you can see that here is a growth plate, or an epiphyseal plate, Here is an epiphyseal plate of the tibia, excuse me, femur. That's a fictitious, it's like a unicorn. It doesn't really exist. The tibia, okay? And this is the fibula. Okay, so even we do it, right? So you're like, how about the, what does everybody call this one instead of the fibula? The tibula, that's right. So the fibula, you can even see the epiphyseal plate on the fibula. If I show you this patient after growth is finished, you can see how you can still see evidence of the scar, but there's no longer a cartilaginous plate. Make sense? All right, what about appositional growth? Oh, whoops, I forgot that I added this. Did you guys get this slide? Okay, you need to download this. This is my oldest daughter. A couple years back. This is when she was 10. We remodeled the kitchen. I put it in X-ray. I'm just kidding, but wouldn't that be cool? I think it would be so cool to have an X-ray machine at home. But no, we actually had to go to a hospital to use this. I mean, right. But anyways, we were just kind of checking out her growth and her development, and she lost the coin toss, so she had to volunteer for this experiment. But you can see at 10, I'm just joking about that. There were other things going on, and we were kind of curious about tracking her growth. Full disclosure, come to turn out that she's a little hypothyroid, so she has to, and in this class of size, some people might be in this category. So she has to take a little bit of thyroid hormone every morning just to make sure that her thyroid's kind of not overworking, especially for, she's 12 now. So things are going really well, but this is when we were discovering what was happening. And one of the things that the physicians were a little concerned about is just her rate of growth. And with her rate of growth, they decided that we would flicker the screen a million times to see what happened. But with measuring her rate of growth, the idea is, what is her chronological age and what is her bone age? Bone age is the integrity of the plates. Kara, did I do something up here? Or, okay, no? We're back? Or no? Well, maybe it doesn't like x-rays. Maybe I should just move on. Okay, look real quick at the arrows. See the arrows? Oh. So these arrows are the growth plates. You can see them even in the short bones of the hand. Okay, so they discovered that at this, and you can measure them, and you can actually quantify, based upon the density and the presence of cartilage versus bone, how old is she bone-wise. So the bone age was about 8 to 8.5. Okay, so they were a little nervous that maybe she was not growing quite as fast. Well, she's just not maturing as quickly. Okay. You gonna fix it for me? Okay. So I'll talk about other things while we're trying to get the slide projector to cooperate. So this is interstitial growth. Interstitial growth is what we define after birth. So during development, we have two different types, and those two types are what? During development in utero. Intramembranous is what type? The first one we covered, which is what? Flat bones of the skull. And endochondral is what? Long bones. Okay, that would be our example. Thank you, Carrie. Let's give Carrie a round of applause. Yeah. She saved the day yet again. And then, now when we finish out birth, we have what we call interstitial growth, where the bones can additionally get longer. And it follows... Oh, that's very common. Oh, look at that. Bones are there. Wow. I almost want to let it just play. I would have expected this on Friday, but not today. Friday was 13th. So now we have birth, we have interstitial, we additionally lengthen the bones. We use the same types of processes we find in endochondral, and we use a cartilaginous model. Well, now if we want to thicken the bones, okay? It's not, and you've seen this developmentally, right? In junior high and high school, there are some kids that just like shoot up like beanstalks, and they're about, you know, that big around, okay? And then they start filling out, as we say, right? Well, the idea here is your bones lengthen, and then they're going to grow in size or in diameter, okay? And then for the rest of your life, after the growth plates close, you're going to still have the ability to increase or decrease the diameter of your bones based upon the stress that you put on your bones. But you won't necessarily grow them any longer. Okay? So this is called appositional growth. Appositional growth helps not only to make them just, so you're like, well, who cares if they're thick or thin? Well, if you're doing heavier weight-bearing activities, if you're a football player or a professional athlete versus if you're a swimmer, you're going to have different densities of bone. Okay? Also, it helps to maintain the proper shape of the bone. So you can see that there are two different shaped bones here. One that's filled in with this pseudocolor, and the other one that's traced with the black line. And to go from this shape to that shape, or that shape to this shape, is a change in apposition, or appositional growth. The osteoclast and the endosteum help to dissolve the bone as we go through life, and that helps to expand the medullary cavity, or keep it hollow. The osteoblasts and the periosteum produce new bone, and that actually helps with our diameter or increase in size. So there is a constant balance between these two events. The balance that takes place is important, and it's very dependent upon the types of stresses that you put on the bone. So the types of stress that you put on the bone, if you have more weight-bearing activity, you're going to actually thicken or densify the bone to a greater extent. That's relevant in our older patients, especially our postmenopausal women. Those are the population that are at most risk of developing osteoporosis. We're going to talk about that more on Wednesday. Now, it's not just women, guys. You can't just tune out like, oh, I'm not a girl. Osteoporosis affects everybody. Men just have a delayed effect of osteoporosis, and we'll talk about that. The other thing that's important to remember is this phase of your life is where you're developing the greatest bank of bone density that you're going to have for the rest of your life. Okay? It's another way of saying it's all downhill from here. Okay? So you might as well take advantage of that development. As appositional growth occurs, this is a picture from a different textbook that I put in here. That x-ray of my daughter's, that hand x-ray, is actually reposted. So it depends on when you downloaded your slides. If you really want to see that, you can download it. But it's kind of cool to demonstrate that it's not just long bones. The short bones, that's why our hands get bigger. Like our hands are not the size they were when we were 5. Okay, they actually do get a little bit bigger. The osteon, as it grows in apposition, right, as the diameter grows, it maintains this organizational structure of bone. As it maintains the organizational structure of bone, it keeps true to developing a new osteon about every 200 to 250 microns. What's so secret about that distance? Or what's so special? Not necessarily secret. Should be a secret now. The diffusion distance of oxygen. So if the bone's going to get thicker now, instead of longer, you're going to add new osteons with a new blood supply so that you don't run out of oxygen as you get further and further away from the blood vessel. So here's the process that takes place. This is from a biomechanics text, not your text. But so you don't have to buy another textbook. I've just put the relevant slides and material in here. Remember back when we were in utero talking about this in the last lecture. We built everything around the vascular supply. Whether it was intramembranous with the flat bones, or endochondral with the long bones, it all harbored around a blood supply. Same thing here. Step number 1, you put a blood vessel in first. And then you actually hollow out a piece of bone around it as it grows. You create a groove and then a ridge. Eventually you enclose it. As you enclose it, you start hardening the bone, and you create this periosteum on the outside and the endosteum on the inside. This is the development of your osteon. Right? And then more appositional growth occurs by the formation of additional concentric lamella. As you fill it in, here is your osteon with the blood right down the central canal. So is it possible that this week you have a different number of osteons than you did last week? Sure. Maybe not week by week, but what about this year versus last year? If you're training at a higher intensity this year, I guarantee you the number of osteons that you have in your long bones are going to be a greater number than they were the year before. Same thing is true if you're a patient and you're on bed rest this year, and or maybe you were confined to a wheelchair for 6 months. Instead of growing in diameter, it also shrinks in diameter as well. Okay? But as bone grows appositionally, we maintain this concept known as the moment of inertia. This is where everybody freaks out in the class. They're like, holy cow, that looks like a formula. So can we use, I want to hear it, can we use a calculator on the exam? Okay. I don't care about calculations here. I want you to understand the concept. So the concept here is the moment of inertia is I. It's equal to the mass times the radius squared. So if you remember back to algebra, basic algebra, when you read a formula and you see something taken to a power, what is that supposed to tell you? What's that? Pay extra close attention, right? It's probably one of the more important things that's going on here. So the moment of inertia is defined as the resistance to bending. That's what moment of inertia means. Is it has a resistance to bending. And so what this formula is saying then is the resistance to bending is equivalent to the amount of mass that you put farther away from the neutral axis. Because if you put more of the mass a larger radius away, the radius is to the squared power. Make sense? For those that are mathematically inclined, you're all sweet, totally get it. Others are like, is that a capital I? Or is that an L? Right? So, another way of saying this, it's a capital I, by the way, is if you look at these pictures. If I have this A, B, and C, and the black filled in area represents the amount of mass. And if I told you in this rod that's solid has the same amount of mass as this rod, which has the same amount of mass as this rod. How is that true? Well, the diameter is increasing, but the relative amount of stuff is the same. So the further away from that center neutral axis, which would be right here, right down the center, you put the mass, the greater it is, has a greater resistance to bending, meaning it's harder to actually bend that rod. Some of you don't believe me. You're like, no, a solid rod is way harder to bend than a hollow rod. It's not true. Remember, you have to bend a larger radius. Okay? So the body creates these hollowed out long bones with this moment of inertia that have, a 700%, 7 times the resistance to bending than if we maintain a solid tube. Pretty crazy, huh? So not only do the long bones with a medullary space actually house valuable hematopoietic tissue that makes blood cells, red blood cells and white blood cells, that help carry oxygen throughout the blood, that actually help fight infection with white blood cells, that produce platelets to clot the blood. Now they actually create a structure that mechanically is stronger than if it was actually solid. Isn't that pretty Neat? I think it's pretty cool.
So is mass a constant in this?
Yeah, mass would be a constant here. We're only changing radius. That's a good question. Okay, questions about that? Let's talk about how the bones are modeled as we age. As we're in our adult life, what's taking place? So I want you to turn to the person next to you, and I want you to quickly describe intramembranous versus endochondral. Let's just see if we've got these concepts down from the last lecture. How well do you guys know this? How well do you guys know this? Not well? So here is a homework assignment. Okay? I want you guys to work on this before Wednesday. I want you to be able to fill out this chart. Okay? This is something that we'll go over in SI. We'll walk through this in SI session. But consider this due Wednesday. Okay? So I want you to make a table. You can just print out the slide if you'd like. And I want you to say, okay, it's yes or no. In intramembranous, which is the first one we did, that's the far right column, does it start with cartilage or does it not? Intramembranous. No, it doesn't. It starts with what? Mesenchyme. Endochondral, which is the left column, which is the second one we did. Does it start with cartilage? Yes, it does. So there's the answer to the first line. And I want you to fill in the rest. Okay? Do you understand the assignment? Okay. Yes or no? You have a 50-50 chance on this. It's like super easy. Okay? Can you put a Y or an N? Sure, as long as the Y looks like a Y and the N looks like an N. Alright, let's try this one. This bone-related event does not involve activity in or on the medullary cavity. Who's got an answer and who can defend it? Endochondral, A. Appositional, B. Intramembranous, C. Two of these do not involve activity in the medullary cavity. That's the evil two of the above. Wow. Who's got an answer? Volunteer. Come on. Who's got an answer? And why? Who can defend it? Oh, come on. You guys aren't that shy, are you? In this small little intimate classroom? No one's got it? How about I tell you the answer and you tell me why? C is the correct answer. Intramembranous. Why? Happens in the skull. Is there any medullary space there? No. Okay? Questions? All right, the last concept I want to talk about today is the epiphyseal plate. So here's our lines that form. Epiphyseal line is when the plate closes. The plate closes in women a little earlier than men. Women usually start puberty a little earlier, and they get a growth spurt quicker than boys or young men. And men stay open a little bit longer to about 21. And that epiphyseal plate converts to a line once they close. Our hormones in childhood, primarily growth hormone and thyroid hormone. That's why thyroid was one that we were concerned about with my daughter. Right? That's why they look at those things. Those significantly will affect what happens at the level of the growth plate. Then you get another burst during puberty of sex hormones. Estrogen and testosterone both influence the rate of bone turnover at the plate. Okay, that's why you get growth spurts during adolescence. That outpaces, the bone formation outpaces the cartilage growth. Okay, and so you get additional bone developing over time. Now what's going on here? This is what we call an androchondroplastic dwarf. A chondroplastic dwarf. That is the technical term. Okay? I don't know what the lingo is today that's supposedly socially acceptable, but these are folks that, little people, I guess is what some people call. But the clinical term is achondroplastic dwarf. What is this? Well, this is a disease. This individual on the right is in college, about your age, and this individual on the left is also in college, same age. So this is an autosomal dominant disease. Right? There's a mutation on the fibroblast growth factor receptor. And this is happening at the plate, the growth plate. And so what happens is there's a failure of proliferation of the cartilage. So the chondrocytes in the growth plate aren't responding to fibroblast growth factor, which causes them to divide. So if you don't get more cartilage proliferating, you don't have as many to get larger, you don't have as many to form bone. Make sense? This happens in the long bones, primarily. So there's a failure of epiphyseal cartilage to grow, so you don't have the template to form bone. That's why I'm showing a picture of that growth plate right here, where you've got bone on the bottom and you have cartilage up top. You don't proliferate the cartilage as aggressively in achondroplastic dwarfism. Well, what are some of the symptoms? Well, the short bones in the hands, the growth is stunted. The long bones, the growth is stunted. So you can see in these patients, they have a adult-sized head because that's flat bones primarily. Okay, and the torso is adult-sized, but it's the long bones like the legs and the arms and the hands that are more like they are in a child. So they're not proportional to, quote-unquote, a typical adult. Okay? Some of the other concerns that we have clinically, other than the short stature, which isn't a big deal, but this can cause problems with the spine. So we get spinal stenosis. We can get a lot of abnormal curvatures of the spine, like scoliosis or abnormal kyphotic curves or lordotic curves. Okay? They do tend to have a prominent frontal bossing because that bone does tend to harden preferentially. Meaning the forehead kind of has a frontal bossing or a pronounced appearance to it. The disproportional appendages. And then later in life, when they take on weight, any of the abnormalities or any of the consequences of abnormal weight gain. Obesity or bowed legs, those kinds of things. Other than that, normal life. But I wanted you to understand a disease that does strike these growth plates and why. Okay? Characteristics and prognosis is pretty good, other than the list that I told you about. In aggressive circumstances, you can actually create what we call distraction osteogenesis. So you can take the long bones and fracture them, move them apart, allow the bone to grow in between, and you can do that slowly over time and lengthen the long bone. Pretty aggressive, but that is a treatment that some have utilized. Okay? Questions? So we'll stop. We'll pick it up on Wednesday here.